Well, good morning, and can I welcome everyone to this, the fourth meeting of the Public Audit Committee in 2025. Agenda item 1 is for members of the committee to decide whether or not this morning to take agenda items 3, 4 and 5 in private. Is the committee agreed? We are agreed. Thank you. And our main item for consideration this morning is the Auditor-General for Scotland's Section 23 report on the NHS in Scotland 2024, which covers its financial position and performance measures. So can I welcome our witnesses to the Public Audit Committee this morning. We're joined by Caroline Lamb, who's the Chief Executive of the National Health Service Scotland and the Director General of Health and Social Care in the Scottish Government. Alongside Caroline Lamb is Alan Gray, who is the Director of Health and Social Care Finance in the Scottish Government. And we're also joined by John Burns, who's the Chief Operating Officer of the NHS in Scotland. We've got questions to put to you over the course of the next hour and a bit. But before we get to those, Caroline Lamb, could I ask you to provide us with a short opening statement?
Thank you very much, Convener. I welcome the report of Audit Scotland, and as I've stated before, I see the close engagement between my team and Audit Scotland as incredibly important. In his speech on Monday, the First Minister set out clear priorities for NHS Scotland, together with a commitment to deliver further detailed plans over the next few months. And the Scottish Government's draft budget, if passed by Parliament, will provide a record £21 billion for health and social care, including, importantly, £200 million to reduce waiting lists, to increase capacity, all of which will help to improve the flow of patients through hospital and reduce pressures on both urgent and planned care. We are determined to continue to improve the performance of our NHS, and as we work to deliver on the Cabinet Secretary's and First Minister's priorities, we will pay careful attention to the Audit Scotland's recommendations. I'd be very happy to take questions. Thank you.
Thank you very much indeed. Can I begin by asking you with that perennial question, do you accept the findings and recommendations of this Auditor-General report?
Yes, Convener, we accept the findings and recommendations, and as I've said, we'll be working carefully we already are working carefully to consider how we can how we use those recommendations in the work that we're taking forwards.
Thank you very much for putting that on the record. Can I turn to the review of actions since the last report was issued and the Appendix 2, which charts the progress been made since the NHS in Scotland 2023 report. And in broad terms, the Auditor-General finds that some of the recommendations made last year are in progress. The medium-term financial strategy, which this committee has been concerned about because of its delayed announcement. I think we're expecting that now to be in spring of this year. He also notes that in progress is the National Workforce Strategy, although he does say that no timeline is confirmed. He then talks about limited progress on a long-term vision. And he says the restated vision from the Scottish Government does not clearly set out national priorities or provide a framework for reform. I wonder whether you could comment on those areas, first of all.
Yeah, absolutely. So I think in relation to, maybe if I start with the vision and the restated vision. So as the First Minister set out on Monday, and I think as well some more detail was provided in the GIQ, the plans that he set out in outline in his speech on Monday are being worked up with our NHS boards, which again was another recommendation of NHS Scotland, into a detailed operational delivery plan that will be published by the end of March. We're also committed to producing the Population Health Improvement Framework, which, again, substantial work has been undertaken with partners, including, importantly, COSLA, and that will be published in the spring. And we've committed to publishing a framework for the medium-term reform of health and social care by the summer recess. And I think it's important to set those areas out. That's not to say that there hasn't already been a lot of work underway on the components of those, and I'm sure we can go into more detail with the committee about those. But I think that then links very much back to the workforce strategy and to considering that commitment to provide an update to the workforce strategy, because I think that will need to take into account that detailed operational measures to make the best use of the resources that we have in the short term, whilst at the same time looking at what we need to do to deliver that ambition to shift more more activity into primary and community care, and that longer-term reshaping of NHS services. So work is underway to look at all of that and to understand that, and also to understand, importantly, the impact of increased use of digital and innovation on the workforce. So we need to incorporate all of that into a refresh of the National Workforce Strategy.
Yeah. And so in the speech that the First Minister made on Monday, he said we need to put in place clear milestones and targets, which is kind of music to the ears of the Public Audit Committee and the Auditor General, I'm sure. But the problem is we've heard that before so many times. I mean, when we look at let's look at the areas where the Auditor General identifies there has been no progress. No progress. The annual recovery plan update. I mean, so the annual recovery plan update and the whole recovery plan was first instituted in August 2021. And there is a real lack of transparency around that. He also notes the annual updates that we expect on service reform are not there either. Why only now, 2 days ago, is it necessary to once again say we need a new clear direction and we're going to set out milestones, when the evidence before us appears to be that even when ambitions are set, progress reports aren't made, milestones aren't clear, there isn't that real sense of progress being made. So why is this time going to be any different?
So first of all, Convener, what I would say is that we did publish an update to the original 2021 NHS Recovery Plan. It was published after the Auditor General produced his report. However, I think we do accept that we need to be much clearer about the metrics that we're using to measure improvement and being able to demonstrate the impact that our reforms make. And a lot of that is linked to the ways in which we have been changing and improving and evolving the way in which the system runs. So the Auditor General himself in his report reflected on the fact that our traditional ways of capturing activity in our A&E departments didn't include some of the developments that have been made through the establishment of flow navigation centres and the ability to book people in for appointments at ED. So work has been underway, and from the beginning of this year, our reporting will include and will capture that activity. So we have been in a bit of a process of needing to catch up our reporting and our metrics with the changes that we have been making and the improvements that we've been making to the way in which services have operated. The Auditor General, excuse me, I think was also very clear that he expected Scottish Government to work with NHS boards in developing those plans, and that is absolutely what we have been doing with NHS boards. And the detailed operational plan that we publish in March will be a plan that has been worked through in collaboration with NHS boards. So we're really clear about what NHS boards will be delivering in terms of their core capacity and what that additional funding, which is critical to this, will provide as well. And yes, we will absolutely be looking to provide very clear milestones in terms of that short-term improvement, but also looking to, and it may well be an iterative process, because we will need to work with Public Health Scotland around new data sets that can be made, that can be put into the public domain, that will increasingly enable us to capture new areas of activity. So, for example, active clinical triage and being able to capture the activity that goes through that, which again is a new way of thinking about how we provide services. Patient-initiated review. I think at the moment the activity levels that we're capturing slightly undersell what we're doing, and we're very keen to be able to address that.
Okay. Well, I mean, let's have a look at a couple of those. Again, the First Minister reminded us on Monday that last year he referred to delayed discharge as the canary in the coal mine of our National Health Service. Paragraph 80 of this report says delayed discharge rates are at the highest on record. So what's the state of the canary at the moment?
So I think none of us would argue that delayed discharges are at an unacceptably high level, and that is that has an impact on the ability of our health service to function efficiently and effectively. It means that our hospitals are far fuller than they should be for efficient operation, and that impacts on the way in which we run our services and our ability to see people quickly, whether they present either as an emergency, as an unscheduled, or as a planned care patient. But much more importantly than that, it also impacts on the people concerned. So we know that it is really bad for people to be in hospital when they don't need to be in hospital. And this is a complex and multifaceted issue. So to address delayed discharges, we need to work. It's not something that the NHS can pull all the levers on. There are absolutely things that the NHS can do around increasing the number of short stays where people don't need care at home and therefore don't need support to be discharged, and reducing the number of very long stays, again, for people who don't need support after they've been discharged. But in terms of those people who need support to be able to get home or into a homely environment, we need to work with partners. And since the summer, the Cabinet Secretary and the Minister for Social Care have been convening partners together through our Collaborative Response and Action Group. That involves, that's been co-chaired by COSLA, so Paul Kelly has been co-chairing those meetings, and that has had an absolute focus on what are the things that are happening in the areas that perform better, because there is variation across Scotland in this. We see some areas that perform extremely well and some areas that don't perform so well. And so the interventions that we've been making at a national level have been about exposing that data, being able to really clearly understand where areas are performing well and where clear areas are not performing so well, understanding what it is that helps to drive improved performance, and then seeking to challenge that performance. The announcement that the First Minister made on Monday and the Scottish Budget, as I've said, provides 200 million both to address elective waiting times, but also to do the things that we know will help to prevent people from being admitted to hospital in the first place and to enable them to be discharged as quickly as possible.
But on the subject of delayed discharge, you are the accountable officer for health and social care, which is the other key component in resolving the delayed discharge crisis. Don't you accept any responsibility for that?
So I absolutely accept that the position is not where we would want to be for delayed discharge. And yes, my title is Director General for Health and Social Care. But actually, the vast amount and the health part of the portfolio makes significant contributions into the social care budget and has done for a number of years. But actually, the operationalisation of that, the actual allocation of funds into our integrated joint boards and our health and social care partnerships is driven by health boards, who we clearly have strong levels of influence over, and local government. And we need all those partners to come together and play their part, which is why we've been convening the CRAG group and looking to ensure that local systems understand where they are in terms of good or poor performance and what they can do to improve that performance.
Okay. You mentioned about regional variations, and again, if we look at the appendix in this Audit Scotland report, there are some quite marked variations in some of these measures. And if we look, for example, at suspected cancer referrals and the 62-day treatment guarantee, I mean, the area, the two health boards in the area I represent, Forth Valley, against a target of 95%, are at 83%, Lanarkshire 89%. But then when I look at NHS Shetland, it's 50% against a target of 95%. If I look at Tayside and Grampian Health Board areas, they're both just at 60%. Why? I mean, what analysis have you done to understand why there is such a variance between different health boards and different health board areas?
So I think so our approach to that, first of all, is to seek to set out for health board areas what good looks like. So what good looks like in terms of rapid assessment and treatment of cancer. And we know that where NHS boards have taken steps to really look at that framework and to really challenge themselves against that, then they have achieved substantial improvements. Lanarkshire is absolutely, as you point to, the performance in Lanarkshire, that has improved substantially and continues to improve, and that is really good news. We are now working with all NHS boards to understand that they learn from what Lanarkshire have done, and that they look at each of the steps set out in that framework and are able to assess where they are individually and, as I said, learn from what Lanarkshire and other areas have done in really improving performance in that area, because I think what Lanarkshire and indeed Forth Valley have done proves that this is possible, and some of that is about cutting out unnecessary steps, making the pathway much smoother. We just need to make sure that's happening in every area, and also to ensure that there aren't particular barriers, maybe particularly in some of our island boards, and look to make sure that we're addressing those as well.
OK, but to give a fuller picture, if I look, though, at the A&E stats, NHS Forth Valley and NHS Lanarkshire perform very, very poorly, don't they? I mean, they're down, again, the target of people receiving treatment within 4 hours, a statutory target, as I recall. The performance of NHS Lanarkshire is 55% against a 95% target, and Forth Valley is 54%. Can I ask you a question that was posed to the Auditor General when he was here? You know, is there any correlation between poor performance in A&E and better performance in some of these other indicators?
So, first of all, first thing I'd say is that, as you've identified, every health system has its own challenges and its own successes. And as you've identified, Tayside perform extremely well against the A&E standard and have some challenges and need to do better against the 62-day cancer target. So, so the work that we do is really about trying to identify what are the things that improve performance across all areas, and to ensure that boards are focused on the measures that they can take, whether that be around unscheduled care, whether that be around treatment pathways, whether that be around productivity in relation to planned care, that they are absolutely focused on what are those metrics and how are they doing against them. I don't think that we can say that there is a clear correlation between doing well in one and not doing so well in the other. I do think there will be underlying issues in every NHS board in relation to its estate, its footprint, its workforce, its capacity. But actually, part of understanding that, what does good look like? What are the things that make a difference? And are you doing all of those in the board areas? And we work with the Centre for Sustainable Delivery to do work with all our boards to ensure that they have the support to make the improvements that they need against those areas. Because if it's possible in one area, then we need to understand what are the absolute barriers, if there are any, that would prevent that from being possible in another area. John, I don't know if do you want to say anything in addition to that?
I think the only
It'll be turned on for you.
Yeah. The only additional point I would make, Convener, is that we are very clear in our engagement with boards around the framework for effective cancer management, and we meet with boards on a very regular basis and their cancer teams to work through their pathways, to give them support and to share that learning. And we have a cancer delivery group that is very focused on this 62-day target, which is where we need to make improvement. And I think in terms of your point, I don't think we can make a direct correlation between good performance in one area. As Caroline has said, there are many different factors that are at play in terms of population demographics, etc., and referral patterns into boards. But we are working, and the Centre for Sustainable Delivery has a key role in helping to bring that understanding and sharing that learning across Scotland.
Okay, and we're going to touch obviously more on some of those performance measures as the morning progresses. Can I take us to another area? And before I do that, I should place on record my membership of 2 trade unions that organise in the National Health Service. But can I turn to staff sickness absence rates, which again is recorded in this annual performance report of the NHS in Scotland as being at a 10-year high. What are you doing to address that, and what's your assessment of it, and how are you going to turn that around?
So, yes, the sickness absence levels are certainly higher than we would want them to be. And again, there is variation across all of our NHS boards. So we have some NHS boards who perform pretty well and are very effective in how they manage sickness absence. And management sickness absence is really about what happens at a local level, what happens in terms of the engagement between a line manager and a staff member who is off sick, and having those really regular engagements, following up and identifying what are the issues that would help somebody to return to work, particularly if it's been a long-term absence. So our expectation is that every board is working through their directors of HR, through their line management structures, through their training and development, so that understanding that line managers feel confident and skilled and able to support staff to get back to work. So all that work we expect to go on at a local level, and we meet regularly with directors of HR to support them in that work. At a national level, we also have interventions around our national workforce support services as well. But on the ground, this is very much a matter for boards to manage, and we do look at the variances across different boards.
But do you have, as the Director General for Health and Social Care, do you have data that shows you the reasons why people are off? Is it? I mean, some of the jobs in the National Health Service are quite physical, manual, handling jobs and so on. And so some people might be off through work-related injury as a result of that. But there is also the possibility of an increase in workplace-related stress. Have you got information, have you got data that lets you know what's going on out there so that it can be tackled and support can be put in where it's needed?
So I would need to come back to you on the absolute detail of the data. At a board level, we absolutely expect boards to be looking at, for example, the balance between musculoskeletal factors, as you said, potentially related to lifting and maybe needing more support in how that happens, and also stress-related illness. I'll need to come back to you about the extent to which we collect that at a national level, because actually the interest in that is what's happening at a board by board level rather than nationally. I think the other thing that we use as well is iMatter, which is the annual staff survey. So that enables us to get, again, that is very much for boards and for teams. So for the iMatter questions are asked at a team level, and the process of iMatter is then for teams to develop their individual action plans. So through that takes a temperature of how people are feeling and enables teams to work together to develop their action plans in terms of identifying the issues that might have emerged through that.
But if you've got a 10-year high of sickness absence amongst the staff in the National Health Service, and the First Minister announces on Monday he wants 150,000 extra appointments and procedures, how are you going to do that unless you tackle that level of staff absence?
So absolutely, tackling staff absence is one of the areas that we expect boards to focus on in terms of their ability to be more efficient, be more productive. It also sits alongside other measures, like for example, reduction of the use of agency staff. And I think the Auditor General recognised in his report that we have seen some successes alongside that, and indeed successes in terms of a reduction in the number of vacancies across the system. So we accept that having the right workforce in the right place is absolutely fundamental to achieving our ambitions, and we will continue to work with boards and to stress the importance of boards managing and supporting their workforce comprehensively at a local level.
OK, thank you. I'm going to now turn to Colin Beattie, who's got some questions to put to you. Colin.
Thank you, Convener. Morning. I'd like to cover various aspects of financial sustainability.
Okay.
NHS funding in 23-24 grew by 2.5% in real terms, but that increase mainly went to pay rises and inflation. Health is the biggest single area of government spending. In 23-24 it was 40% of the Scottish budget. The affordability of healthcare spending is a big issue now. I mean, it's always a big issue, but it's even more urgent now and needs to be addressed, and the scale and pace of reform needs to increase. And I think that was emphasised in the course of the First Minister's speech on Monday. I'd like to look at some different aspects that come about in the financial sustainability side. One of them is drug costs, prescriptions, the cost of that. The Auditor General has told us that there's been some analysis done on pay awards, but there seems to have been nothing on drug costs and the drivers behind drug costs. Now, of course, as a society, we're getting older, we have longer-term illnesses and so forth, but we don't know what proportion of the drugs, for example, that takes up. What's the cost to that? What's the projections on that? Do you have any information on that?
So the first thing I'd say around prescribing costs is, yeah, you're absolutely right. The prescribing costs is a significant pressure on the budgets of all our NHS boards. And we seek to support boards to manage that in a number of different ways. So first of all, again, I think comparisons across different NHS board areas are really helpful in this. So we've had a real focus on the replacement of some of the more expensive drugs with more generic drugs that are cheaper. We've had a real focus on polypharmacy and making sure that people are not being prescribed more drugs than they need to be prescribed, better for them and also better for the public purse. But as well as at the other end of the spectrum, you've also got the growth in new medicines and in new very expensive medicines as well. So we have a process of horizon scanning to support boards to understand what might be coming and what might be being approved through the approval mechanisms, and working with boards to understand how we can best accommodate that. But we do need to, I think, continue to focus on our data in this area. It is one of the areas that we ask boards to focus on, particularly in terms of their efficiency and productivity measures. Alan, do you want to say anything more about that?
I think you've covered the main aspects of what we're trying to do. So we do have quite a lot of information, particularly around primary care prescribing. So a lot of focus on moving from branded to genetics, looking at polypharmacy and reducing the number of medicines prescribed to people. Also within secondary care, each board has a formulary, so there's a controlled process through which drugs are added or taken off the formulary and made available for patient treatment. And as Caroline said, the DG said that growth in new medicines, particularly those for rare and orphan drugs, are increasing year on year. So looking at numbers here, I think the growth in the last year was 2.4%, which is broadly in line with our increase in expenditure. Over the last 5 years, it's 5.2%. So it's probably not the biggest single thing driving our expenditure. I think you made the point around our staff costs. If we were to look at staff costs, that's the thing that's probably driving our expenditure in a much higher way than drugs and prescribing.
What's the current percentage of staff costs?
We spend just over £11 billion on directly employed staff against a budget or a net expenditure of £18.4 billion. So it's about 60% goes direct to staff costs. In addition to that, of course, we pay for primary care contractors who are in effect staff but employed through a contractual arrangement with the NHS. So if you add that in, it probably moves the number of total people costs, including the primary care contractors, closer to 65 to 70% of our costs go on people, actually directly on people.
Which is a very high percentage, but of course the NHS is a people organisation. You need the bodies there to deal with the patients. Unfortunately, robots are not yet available for that. How do we compare with other health boards and so on, both south of the border and on the continent? Do we know?
In terms of, if you look to OECD countries, generally the UK employs fewer doctors and nurses than OECD countries, so that's a factor. Compared to England, we employ more staff. We employ broadly the same number proportionally of doctors, but we employ more nurses and we employ more staff in other roles to support the health service. So we have a bigger staff base than our equivalents in England. I think we're probably comparable with Wales. I don't have a number for Ireland to comparison by, but I know that Wales and ourselves are probably comparable in terms of staff numbers. But England, we definitely have a significantly higher number of staff compared to NHS England.
So I said that it's a people-driven organisation, inevitably. How we compare ourselves quite often to south of the border as to how well we're doing and so on. We've got all these additional staff, the higher headcount than south of the border. Why aren't we exponentially better?
I think there's a number of factors that you look at there. It's quite hard to make direct comparisons, both in terms of how we actually count things. So it's hard to make absolutely direct comparisons between the performance figures published in England and those that we publish. But I think the other things that we have to take into account is around areas, we have the particulars around the Scottish demographics, around the nature of our population and the nature of the rurality of our population as well. So we do have more staff. We also pay them slightly more than they get paid in England as well. So we have more staff and we reward them better. So I think that in itself means that sometimes we have had less money available to spend on other innovations like digital, for example. But that's one of the areas that we're expanding at the moment.
But if we took simple areas that are quantifiable, like drug costs and so on, how does that compare with the sort of percentages they're spending elsewhere?
Elsewhere in the country. I don't know, Alan, do we have those figures?
I don't have the direct numbers. We could find out. I think we're broadly in line. We're not too out of sync. The things that are a bit different in Scotland are we've got a slightly different process for going through new drugs, for awarding or bringing new drugs onto the SMC. So we have a slightly lower threshold for bringing in new drugs. So we introduce new drugs with a slightly lower affordability threshold than England. But broadly, I don't think we're too far out of line, but we can provide further information to the committee to.
Just moving on to another aspect. Obviously, different health boards have been under different pressures over the years, and this committee has been involved very much in looking at that. In 23-24, there was eight territorial boards that required brokerage, and boards are forecasting recurring deficits over the next 3 years, which must create a risk to financial sustainability. I'm looking at brokerage and wondering, well, firstly, why are these recurring brokerage issues coming up? Why are these particular boards under the pressure they are? And it seems that the Scottish Government's trying to take away brokerage, or at least its policy is to do away with brokerage over a fairly short period, which isn't evidenced by what we're being told in the Auditor General's report.
So you're absolutely correct that we have a number of boards who have been in receipt of brokerage over more than 1 year, and our approach, I think, is to be really clear that we can't shift into a culture where brokerage is always seen as being an option. We need to work with our boards to get back to a position where they are able to balance, and that might not be over the period of 1 or 2. It may take a period of 2, 3 more financial years, but we need our boards to be planning on that basis. And I think the Auditor General in his report recognises the amount of support that we, from Scottish Government, are providing to boards, absolutely, to support them to get back into that balanced position. And Alan, do you want to say a little bit more about the support we're providing?
Yeah, so we provide a range of support. So clearly we've got an escalation scale that allows us to put different types of support depending where the board are in terms of financial deficit. So we've got 5 boards currently at level 3, which requires us to have a more closely monitoring. So we provide we have a monthly conversation with each of the chief execs and directors of finance. But we also put in place external support. So a range of different external support has been offered to each of these boards, depending on the circumstances. Some might want support to help with operational issues, linked to the financial performance, and some are looking to help develop their savings plans in a bit more detail. So we've provided a range of, our access to a range of different organisations to help support the board to develop plans. And I think we made a clear signal that really from the start of next year, we want to see boards starting to turn back to financial balance and taking the steps and actions to do that over a reasonable time period. So I want to reassure the committee that we're not aiming to do things without due care and attention, but we do need to start to move away from brokerage becoming an increasing part of what we fund to one that actually we're seeing boards return back to a sustainable position of financial balance.
And I think if I can maybe add to that, I think this also links to the objectives that the First Minister set out on Monday in terms of there is. In the short term, this is about making the absolute best use of the resources that we already have in terms of trying to improve performance, but recognising that, as yourself has recognised, that the proportion of the Scottish budget that goes to health cannot carry on increasing exponentially. And to address that, we need to tackle the underlying causes of that ill health in Scotland. And that isn't just for the health service to do. That is a cross-government endeavour, a cross-society endeavour. And that's why we will be coming forward with the production of a population health improvement framework in the spring. And that we also then need to look at how we are going to, and we are, as you've heard already, there are already lots of developments that have happened around how we can deliver health services in a different way, more efficiently and more effectively. And we need boards to be looking at that locally with their partners. We need them to be working regionally and collaboratively. And we also need to be, from a national and a Scottish Government perspective, ensuring that we are able to provide that innovation and the infrastructure that enables the health service to shift to doing things in a more sustainable manner.
What's the main driver for these needs for brokerage? What is it? Is it staff costs that are driving it? Is it drugs?
There's a range of factors, and part of it's due to ability to recruit staff, so having to maybe recruit additional locum staff. So you go further north or further south of the central belt, there are more challenges around recruiting staff, so that does increase the costs. Geography and delivery of service across a large geographic area. So Highland is, for instance, Ayrshire, Grampian to a certain extent have large geographical areas to cover, so that does incur additional costs. And there are variations. There are just variations in terms of operational performance. So some of the things that Caroline and John had highlighted earlier around operational performance, that impacts on the financial position. So longer lengths of stay, for instance, can impact the number of beds that boards are carrying, funded or unfunded. So there's a number of factors that are contributing to the...
Surely factors like in the Highlands where you're covering greater areas at greater cost, that shouldn't incur brokerage. That should be part of the cost of running the health board in that area, because it's never going to go away.
Yeah.
It's part and parcel of the delivery of the services. So to say that that's part of the contribution towards brokerage needs doesn't seem very valid.
Yeah, the NRAC formula way which allocate funding does take account of reality. So boards that have a greater population that are more rural do receive a higher proportion of funding as a result through the NRAC formula. So the NRAC formula does recognise geographical and rurality in terms of the funding that we allocate.
So if they need brokerage, it won't be caused by the fact they've got the additional costs of the geographical areas?
I think that's when we could separate out where the additional costs are justified as opposed to where we think there are opportunities to make financial savings. So that bit about reducing variation, there are still opportunities for us to reduce the variation, even in those boards in financial deficits. So I think there are opportunities for us still to reduce the level of deficit these boards are incurring. I do recognise you're right, there will be a point at which we've got to balance off the additional costs of providing services, whether it be additional staffing costs or additional costs connected to the geography and location. But I think there are still opportunities for us to reduce the deficits in these boards to get them back closer to a position of balance.
To move to an area which affects every single board is non-recurring costs. Non-recurring costs seem to be almost embedded every year as a high percentage, sometimes the majority of the savings that different boards achieve. And that's not necessarily anything to do with brokerage, it's across the board. How possible is it to move boards away from these non-recurring costs? Because, you know, long term, that's not sustainable.
No, I agree. And what we've tried to do this year is do two things. Increase the amount of savings we're delivering. So we will deliver about £600 million of savings this year, which is higher than the figures for last year at 470. And we'll deliver £300 million this year on a recurring basis compared to £173 million. So we've set a 3% target. We're not there yet. But the work that we're doing with boards, closely with boards through the financial delivery units, to support boards to move closer to achieving a 3% recurring savings target. It's absolutely right, because we don't do it on a recurring basis. You start the following year having to make the same non-recurring savings again. So we are moving to a greater proportion of savings being delivered on a recurring basis and delivering a greater level of savings in total to try and get back to a more sustainable financial position.
Problem is, you know, for years now, this committee's been seeing the reports coming in about non-recurring expenses, and it's almost a core part of every board's annual activity. How are you going to get this away? I mean, you're talking about reform and changing the health service, the way the delivery is made and all the rest of it. But with such a significant proportion of non-recurring expenses, how are you going to balance the books?
Yeah.
Because, I mean, you're just playing about with numbers, really.
But as I say, the evidence issue we've got, we are delivering more on a recurring basis. So we are moving to a position where more savings are being delivered on a recurring basis. We'll never get to 100% because there will always be opportunities to make non-recurring savings, which of course we'll take as part of our financial planning. There will always be non-recurring savings, you know, so vacancies in staff posts that would create a non-recurring saving for a board. It creates an operational pressure, but it creates a non-recurring saving. So I think that we'll always have non-recurring savings that we have to take account of. What I'm saying is that we are moving, and the numbers show that we are moving to a greater proportion of savings being delivered on a recurring basis. And I think that's absolutely the right direction to. So we've made a very focused effort on that, working with boards, and that's starting now to deliver, and hoping that will reflect it.
In past reports coming to this committee, there's been no indication of any significant improvement in non-recurring expenses. What's happening now that's going to make that difference?
We established within my directorate a financial delivery unit, which is providing direct support to boards. So we're providing direct support to boards. We're asking boards to...
Sorry to interrupt, but when was that established?
About 18 months ago.
18 months ago?
Yeah. So you're starting to see the results of that now, that investment now starting to follow through. So when you hopefully see the report next year, that you'll see that we have delivered more on a recurring basis. That strategy, that approach is starting now to deliver. And it's starting to show in terms of not only the total number of savings, but a higher level of savings in total delivered and a greater proportion on recurring. It's still not at 3%, so I think there's more that we can do. And you know, I accept the challenge of the committee to drive that up, but we are moving in the right direction.
Are there any indications that this drive for efficiency savings is impacting on service delivery or performance?
It's very much linked to that. What we're trying to do is identify where there are opportunities. We're looking at comparisons, benchmarking, where there are opportunities to reduce variation, because, as Caroline has indicated, there is variation. You highlight yourself in your own report on innovation performance, but variation in terms of how efficient or effective boards are, sharing our best practice. And that's what we're trying to do, is to look at where best practice is working and to share that and implement that more consistently across Scotland. And that's starting to bear fruits. The agency work that I think referred to earlier, a concentrated effort nationally led by the Chief Nursing Officer and an interim the Chief Executive. And that's delivering change because we've worked on this together. We're making some clear decisions and choices about how we deploy staff and that's starting to deliver savings. So the more we do together, the more we share the information and data we've got, the more we share best practice. I think that's the approach, and that's probably the way that you manage the risk then of doing things that might be counterproductive to.
Just one final question. The brokerage and Scottish Government wanting to put a cap in on additional financial support that might be available to boards in 24-25. What happens if they exceed that cap?
Quite a number of the boards will exceed their cap, hence the reason that we need to change our approach to try and get boards back into financial balance, looking at a 3 to 5 year financial strategy to try and help them do that. So a number of the boards that's highlighted in the Audit Scotland report, they will breach their cap. And that's one of the reasons that we had made it a point that we need to change the approach to managing financial deficits and working with boards in a different way to reduce their financial gaps. So I agree that it's not the way to go forward. Brokerage was always intended to provide short-term funding where a board went into a small amount of deficit and could repay back the following year. We've got a situation now where that brokerage is unlikely to be repayable anytime soon. So we need to change our approach. And that's what I'm proposing. We change our approach. We're seeing that in the bit of focus on recurring savings. I think we've got more to do. The reform bit's going to clearly play a part. And I think we need to move to a position where we're living within our means, we're delivering savings, and we're delivering productivity and types of services that the people of Scotland would like to see here.
Thank you. Thank you.
OK, thank you very much indeed. I'm going to move straight on now and invite Graham Simpson to put some questions to you. Graham.
Yeah, thanks very much, Convener, and good morning. I just want to follow up on that last question about brokerage. People watching this committee might not know what brokerage is, but it's essentially, if I could put it into layman's terms, it's bailing out boards because they're overspending and they need extra money. And to follow up on Colin Beattie's question, which I don't think was fully answered, what happens if a board says, well, actually, we just can't do it. We need extra money. So I know, Mr. Gray, you want to move away from that model, rightly so, but there will be circumstances where boards just can't meet the budget. So what do you do then?
Yeah, maybe start on this, but then hand over to Alan. So I think this is all about our engagement with the board. So as Alan said, we are, Alan, his team, the Financial Support Unit are meeting really, really regularly with boards to understand what the position is and for us to take assurances that they are doing everything that they can. But this is a conversation. Those brokerage caps were set at the beginning of the year. We review them as we go through the year, and that's the approach we're taking. But equally, as Alan says, I think we need to get away from this concept of brokerage as being a sort of short-term measure and absolutely move towards that more sustainable approach of delivering recurrent savings. Is that fair, Alan?
Yeah, nothing more. Does that answer the...
And I'm just trying to think realistically. So realistically, I can't see the government putting itself in a position where if a board comes to it and says, look, we're really struggling here, that you are going to say no.
No, I agree, and it's part of our cause I guess as a portfolio, we've got to balance our overall positions. So in terms of our financial planning, if a board is going to exceed the plan that we've agreed with them, then we need to take different measures within our portfolio to make sure that we have sufficient provision to cover that deficit. My preference would be that we direct money where we can see a return rather than funding a deficit position. So we do need to address it. If a board does exceed its financial target or its brokerage agreement with us, then we need to reflect that. That becomes our responsibility, my responsibility, DG, to manage that as part of our overall directorate budget and path to balance. So it does have consequences for the money that we then have available and flexible to support improvements in patient care or to direct that money to investments in areas where we see the need. So I think there's a need to address the deficit. I think we need to manage it in a sensible way. I think we need to away from brokerage because brokerage, the culture's wrong. There are people that assume that brokerage will be made available. We don't have that money. We don't have that money. There's choices, difficult choices being made if a board exceeds its plans. So.
Okay. Difficult choices.
Yeah.
So if we can go back right to the start, Ms Lamb, and you were talking about the announcement made by the First Minister and indeed the Health Secretary as well earlier this week. So they made a whole series of pledges, and you said there's going to be a delivery plan for that at the end of March. So it sounded to me from that the First Minister's made all these pledges with no idea how to achieve them.
So that is not the position. The pledges that were made by the First Minister are around areas and commitments that have been worked up based on modelling, based on engagement with the system. The publication of the detailed plan will come at the end of March. So I think there's actually quite a lot of detail already in the GIQ that was published. The detailed plan will come at the end of March because we have, as I've said, and as Audit Scotland recommended, we have been working very closely with NHS boards to be absolutely clear about the what by when that we're expecting them to deliver, and to assure ourselves around our confidence in that planning. We've also then been looking, and we've been working on, from the announcement of the draft Scottish budget, around that additional investment in waiting times and improving capacity. So there are two things here. There's how we ensure that we are deploying the core allocation in order to deliver against those priorities, and then how we deploy that additional funding in a different way than we have in the past, and we can certainly come on to talk about some examples around that. But how we deploy that, and working with our board so that this is a joint plan that we have assurance in is really important, as is reflecting on the Audit Scotland recommendations and ensuring that we are clear about the metrics that we will use and the milestones that I know this committee would expect to see.
Okay, I think others will probably ask about some of the detail of what was announced earlier in the week, so I'll leave that to them. There's been talk for some time now about having a national conversation on the health service. That's a phrase that's loved by this government, along with task forces and consultations. We get quite a lot of that. And it seems to me that if we actually had a national conversation about the health service, then the Health Secretary wouldn't have time to attend football matches because he would be being told a few home truths by members of the public. So has this so-called conversation actually started, and how long will it take, and what will it cover?
So we have certainly, since the Cabinet Secretary made his statement to Parliament in June last year, he and his officials have been focused on a number of engagements. In doing that, I think we have drawn on the intelligence gathered from previous exercises by organisations such as the Alliance, around being careful not to go out and ask people questions they've already been asked. So we have had the Alliance doing an exercise for us to gather together the results of previous conversations and previous engagements with the public. We have also had an expert reference group, a stakeholder reference group that the Cabinet Secretary has met with. We have drawn on the really extensive engagement with service users and others that was used to develop the propositions around the National Care Service. That was focused on social care, but actually a lot of primary, community and other health services were referenced in that as well. The Cabinet Secretary also engages regularly with staff through staff fora. We have had the Nursing and Midwifery Task Force, which engaged in an extensive listening exercise with nurses and midwives over the course of the last few months. There's also, John, remind me of the
HIS community engagement.
Thank you very much.
Panel, jury.
The citizen panel that produced that discussed our approach to realistic medicine and the use of NHS resources. So there has been a number of elements of work ongoing and as you'll know, the First Minister has also convening a number of round tables. So we will be drawing all of that together in terms of informing the work that we take forwards.
So are you saying that this conversation has started? And
I think the conversation has started at every level. Yeah.
Oh, okay. It just involves there are various parts to it.
Yes, and I think that's appropriate. We have a number of established mechanisms already for engaging with people, and we have been making best use of those and supplementing that with other mechanisms as well.
Okay. I wonder then, in this ongoing conversation, whether you're looking at things that are of limited clinical value. If I can point you to what the Auditor General says, and I'm quoting, the Scottish Government and NHS boards should, he says, ahead of 25-26, jointly identify areas of limited clinical value and consider how services can be provided more efficiently or withdrawn. When I asked him about this, he told me the government itself, in its clinical strategy from 2016, cited a source that said that 20% of medical interventions were of limited value. In our view, and this is the Auditor General speaking, there needs to be transparency around what interventions, exactly in the government's view, are of limited clinical value. So can you tell me what medicines and procedures are of limited or low clinical value, and have you decided which you do not want to proceed with?
So I think we need to just separate out a number of issues here. So I think the first one of them would be, and that quote around the 20%, I think comes from an OECD report, and it's around the extent to which value is added by resource in health systems internationally, or certainly in OECD countries. And I think that our approach to addressing that has been through realistic medicine, and our approach to value-based medicine, which is very much about working with clinicians, about recognising that actually they have a key role as the custodian of NHS resources, because they are actually, it's with clinicians that a lot of the decision-making takes place about the use of NHS resources. And so working with clinicians and with people, and that John's reference to his people, I've forgotten the name, citizen panel, is important there, because that was focused around realistic medicine, and people absolutely supporting that they want to be involved in decisions about their care. They want decisions that are right for them. So there's that's our whole approach through realistic medicine. The Auditor General also, as you recognise in the recommendations, highlighted procedures of limited value. And we have picked up that recommendation and done a bit of work on it. And I think our initial approach as that had indicated that if you pull together a draft list, and I don't have the details, but I can provide you some of the things that would be on that draft list.
Well, just give me an example off the top of your head.
So I think one of the areas under consideration would be around varicose vein treatment. Now, again, I can't give you the detail around that, but I can certainly provide that to you after the committee. But I think that the principle here is that we've had Public Health Scotland do some work around this and have indicated that they see limited potential. They see limited indications of procedures of limited clinical value actually being carried out in Scotland, which is why I'm probably struggling a little bit to give you examples here, because that's what the work that Public Health Scotland has indicated. So I think our approach in relation to the Auditor General's recommendation needs to go a bit broader than that. So it's really around the principles of realistic medicine, how we make sure that the interventions, the medical and clinical interventions we make, are right for people, but also how we ensure that we are delivering services in the best and most effective way possible, so that the right place, right time approach is absolutely critical to there, as is the things that we've set out around, doing more closer to people in the community, around implementing the National Clinical Strategy, and we can come on and talk to the work about that, but also increasing the use of digital and innovation.
Okay, so You mentioned varicose veins.
I'm just going to say I'm not a clinician, so I would need to come back to you around the list.
You mentioned it, so are we potentially talking about not treating people for varicose veins?
So what I would say is that on the Audit Scotland recommendation was around procedures of limited clinical value. I cannot tell you what is on that list. I know that there is a protocol around, and there are protocols being developed around a number of areas. And again, will be a nuanced conversation because it will depend on the actual clinical presentation in each case. So rather than me try and pre-guess this, I think maybe providing you with some further information after the committee would be helpful.
Okay, I think that'd be useful. Now, the Auditor General, he's always talking about the need to reform public services, and he says it again in this report. Paragraph 94, he says, over recent years, we've regularly called for the NHS to drive forward innovation, reform and long-term fundamental change. Our NHS in Scotland 2023 report made clear the urgency of the issues faced. This year's report details a worsening financial position and ongoing performance issues. The need for reform is more urgent than ever. Now, you know, he's basically saying he's not seeing much sign of reform. Do you think the First Minister's announcement earlier this week is a sign that the government does want to reform? And if that is the case, what is it that it wants to change? Where is the reform?
So I think the First Minister, in his announcement on Monday, he set out a couple of areas. So the Auditor General's comments around driving forward innovation, just to give you an example around that. So the First Minister described how in dermatology we have been rolling out a digital dermatology programme. That work has been ongoing through the course of this year and will complete with that being available in GP services across Scotland by the end of April. And that is an absolute example of innovation, and of that innovation being taken forward by NHS Scotland as a sort of team NHS Scotland rather than being dependent on individual boards. So that has been driven through our ANIA, our Advanced National Innovation and Adoption team, housed within the Centre for Sustainable Delivery. It has been a national approach to taking a tried and tested innovation and making sure that it's planned and implemented and rolled out across Scotland in a way that enables the First Minister with confidence to announce that that is going to be in place and it will start making a difference. It already is starting to make a difference to the way in which patients are being treated. So I think that's a really clear example of innovation. I think the First Minister as well also signalled a further shift in the way in which we think about how we address waiting times. So, for example, in the past, if there was additional money available for waiting times, we might have shared that out between NHS boards in a way that enabled them to manage that locally. He clearly signalled that we are taking a different approach to that, so that additional investment will be directed at centres where we know there is that level of protection from the pressures around unscheduled care. So it's very much around directing the resources where we believe we will get the highest level of performance for that money. John, do you want to say something about the specifics on that?
Yeah, yes, I can. So as Caroline has set out, the approach is to use this in a very deliberate and intentional way to support the ambition of improving access and reducing our long waits. And so to do that, we are working to optimise our national treatment centres that are a core part of that protected planned care resource, as well as bringing on additionality where we can protect for particular specialisms a level of service. And so as was set out earlier. In addition to our NTCs, we're looking to bring on additional protected capacity in Gartnavel, maximising and optimising Stracathro, which is an elective facility and very important for the north of Scotland, but also looking at areas like Queen Margaret and Fife, which has a very effective ambulatory care day surgery, 23-hour surgery, and looking to focus on areas like ophthalmology, where we know we can increase throughput. So we're deliberately funding those areas where we know we can deliver improvement and bring down our weights.
Okay, I think the Deputy Convener is going to be asking about waiting times, so I won't. But I will ask you about GPs. Now, I know the Auditor General didn't really cover that in his report, but it's really important. And the First Minister and indeed the Health Secretary mentioned GPs earlier in the week, and they referenced what's known as the 8 a.m. rush. You'll recall a previous session in June when I was talking about GP booking practices. I mentioned that I'd done a survey in Lanarkshire, and it's a pretty mixed picture. And to be fair, not all GPs operate the 8 a.m. rush model. Some of them did, but have moved away from it. So there might be a perception that everyone is operating a system where you have to phone up at 8 a.m, and that's not the case. Not everyone is, but some are, and too many are. And I was in that position where my GP operated that system, and I just found, as someone who has to come to work every day, that was proved impossible. So I actually literally got on my bike. I actually did get on my bike, and I cycled around East Kilbride and found another GP practice that didn't operate that model, and I managed to transfer. But too many constituents of mine don't find that as easy as I did. It's too difficult to switch, even though GPs are they're effectively they're private businesses. So my view was, well, I'm a customer of a business that isn't serving my needs, so I've got the right to move. And I don't think people find that terribly easy. Don't you think it should be made easier for people to switch if the service isn't good enough?
So my focus, I suppose, would be about what we can do working with primary care to ensure that the service is where we want it to be and where people expect it to be. And that's, I think, why the First Minister made the comments that he did on Monday. And we have been clear that I think the things that we hear most from people is that concern about the ability to access appointments at a time convenient to people with their general practitioner. As you'll know, we've done a huge amount of work to increase the support to primary care with the development of multidisciplinary teams, over 4,600 individuals working in professions that support the GPs to be that sort of expert generalist in the community. But equally, we know that general practice is under pressure, and we also know that the changes around employer national insurance contributions will present a further challenge. So what the First Minister has set out is that we will work with the BMA, with the Scottish Committee for General Practice, to develop a quality framework. And that is intended at helping to provide more consistency of approach, so that your own example, so that people in Lanarkshire can expect an equivalent, a similar service from their general practitioner, regardless of where they are in Lanarkshire, or indeed where they are in Scotland. And then the two things that we would want to address there is that access to appointment and appropriate ways for supporting people to get access to appointments. And we're also interested in the conversations around continuity of care, which there's a strong evidence base around, particularly, not for everybody, but particularly for people with complex conditions, with multiple conditions, around the benefits of actually seeing the same GP and seeing, or it might not even be a GP, might be the same practice nurse, might be the same physiotherapist, but having increased continuity of care to support them. So the evidence base on that is strong, and that is something that we'll be taking forward, as I've said, with the GP, with the primary care community.
But just on a practical level, because GPs and GP practices, they are private businesses, you can't make them do anything. Can you? So it may be, the Cabinet Secretary may have this ambition to end the 8 a.m. rush. Realistically, he can't enforce that, can he?
So you're absolutely correct that GPs are not exclusively. There are some practices that are run by NHS boards, but that GPs on the whole are independent contractors, and therefore we need to work with their representative bodies, but we also need to work through health boards and their local medical committees. And Scottish Government has a role here in terms of the national contract for general practice. So there are some levers, but they're different levers.
Okay. So finally, from me, I just want to ask about this NHS app, because I've asked you about that before.
Yep.
We don't have it. They do. If you're lucky enough to be in England, you have access to this app, but we don't have one here, and that's a source of real frustration. In fact, in England, I think you can book GP appointments through the app, and there might be one or two practices in Scotland that have their own individual ones. I think there are, but we don't have a national app. But the announcement earlier this week said that you're getting round to it, and you're going to roll out something in Lanarkshire, which I suppose, from my point of view, is good. So, can you tell us more about that? Where are you, and what is this app going to cover?
Yeah, absolutely. And I'd say from my own part, I think I've been at this committee previously talking about a commitment to deliver the first version of this in March 26. So yeah. I'm delighted that we have managed to bring that forward. And you're right that the early rollout of that will commence in Lanarkshire, because that's where a lot of the work is happening right now. I would need to check, but I think that first of all, one thing I say is I don't think that the NHS app is available across the whole of England, and certainly doesn't have the same functionality on it as across the whole of England. I think there are different bits depending on where you are and what different systems have managed to link into it. But our approach, call it the digital app, call it the digital front door, it's absolutely aimed at providing that consistent experience and access to services across Scotland. So the work that has been done on it so far builds on the national digital platform, which was developed, actually started off during the pandemic as being the platform that held and holds all our vaccination data. That has we've continued to grow that platform. It actually sits at the heart of the work on digital dermatology, holding the data around that as well, and the work that is ongoing. So there's been, I suppose, two really important bits of work. First of all, is just establishing secure access to the app, the platform, whatever we're going to call it, and ensuring that we're able to authenticate people. So the work that's been done to establish the sort of Scottish Government identity has been critical as a dependency of the programme to do that. And the second bit of work that is being tested in Lanarkshire at the moment is the ability then, once you have that secure authentication onto the platform, the ability to deliver secure mail, because one of the other things this is going to do is to enable digital communications, and we want to be absolutely certain that that is secure and that there's, as you will appreciate, this is extremely sensitive information that is being shared. And then the intention, yes, to start with hospital appointment bookings and then move to primary care following that. And I should also just say that we are working very closely with the people developing the NHS app in England, because if there are aspects of their technology and their coding that we can use, we absolutely will. There is some complexity in that, because we have different systems, different structures, different underpinning IT structure in Scotland, but we are looking at that as well.
There was no mention in the Cabinet Secretary's written answer about rolling this out to GP practices. It just mentioned hospital appointments and getting information about local services, updating your personal information. So that's interesting what you say there.
So what the Cabinet Secretary announced is what we are on track to deliver starting from December this year. But that is just the very beginning of the programme. This is then a 5-year programme that rolls out into many other areas. And I think the potential for this is huge. We need to be careful because we are very conscious of digital exclusion, and there have been reports that have been considered around that as well. So this can't be an exclusively digital approach, but we absolutely need to make available to people who are comfortable using that digital approach, and incrementally just keep adding to it and adding to it. So I think there's opportunities for people to get all sorts of additional information and to be able to interact with health services in a very different way.
Okay, thank you very much. I shall leave it there, Convener. I've taken up enough time, but hopefully it was interesting.
Okay, thank you. Yes, and digital exclusion is indeed something that the Public Audit Committee is very interested in tackling. I am conscious of the time, and so I'm going to bring straight away in Stuart McMillan, who's got some questions for you. Stuart.
Thank you, Convener. Good morning. I'm going to ask some questions around the paragraphs 50 to 56 of the Audit Scotland report, and also at the case study 1 on page 24. So certainly paragraph 50 highlights the suggestion that the capital budget will fall again for 24-25. And certainly now that there has been an agreement in the Scottish Parliament with regards to the budget, so the budget clearly will pass. How will this affect the position regarding the national treatment centres and the plans to build more?
Okay, I'll come to Alan in a minute for the detail on this, but as the committee will be aware, two things have happened here really. One is that inflation and capital projects has risen exponentially, and also we've had reductions in our capital funding. And position is still, although we have a capital budget for 25-26, the position is still uncertain in terms of the longer term of that, because obviously we're waiting on the results of UK government spending reviews. So as a result of all of that, we did have to pause the National Treatment Centre, and I'll ask Alan to give you a bit more information in a second about what we do have, what we are planning in our capital budget going forwards. However, I'd also refer you, and we might want to come back to this as well, that to John's answer about how we are not just using the existing, seeking to maximise and optimise the use of our existing national treatment centres, but how we're also looking at other facilities where we can adopt a national treatment centre model and use that and keep that capacity protected for planned care. So we might want to pick that up under another topic, but Alan, do you want to just talk about
that? Clearly, the drop in the budget in this current financial year, 24-25, meant that we had to pause the capital programme, clearly unacceptable to everybody. I think this year's budget, 25-26, we've seen an increase of £139 million. in the health budget, which we welcome. That will allow us to restart the capital programme with the 3 priority projects around Monklands, the High Pavilion and the Belford and Fort William. So it's good that we can progress these business cases. Now, the business cases are not yet complete, so we have to complete the business case and then move to construction. In fact, we're signalling a move to construct and move back to having a programme. We're also embarking on a process now, working with all the boards to do what we call whole system review. First of all, of the existing estate and how we maintain that, because it's always good to replace, but we've got a large estate, 4 million square metres of estate that we have to maintain and keep up to current standards. So we are doing a review of that, and that's likely to highlight a number of challenges around not just backlog maintenance, but needing to bring buildings up to standard to meet current standards, technical and clinical standards. So we await the results of that. They're due in shortly. Over the next quarter, we'll start to see these whole system plans coming through in terms of the existing estate. And then following on from that, linked to the reform, we're going to be looking at what type of estate we will need in the future to be able to meet the reform objectives. So we're moving more into community from acute. How do we redesign our infrastructure to be able to meet the future reform objectives? So we do welcome, we recognise that the dip in the budget, that really was presenting a challenge. The fact we had to pause all the programmes, I think, is not good. The fact that we can restart now is good. I think it gives us an opportunity now to think about the future, what we do in terms of maintain, what buildings we keep, what we maintain, what we exit from, what we repurpose. I think there's always a bit we actually can use the estate in different ways as well. So I think an opportunity now to look ahead. Still a small amount of small money, given that the replacement cost of estate is probably close to £100 billion. So we forget, when we add it all up, it's a large estate, primary scale estate, equipment, some of the most technical equipment you'll see in any infrastructure. So a big challenge, but at least we've got a start now. 25/6 this thing was a start in the process of starting to build the capital plans and working with boards again to clarify how we address the risks and issues that they are facing currently.
That's very helpful, certainly. I was going to come back to Mr Burns with regards to Inverclyde anyway, and the IRH, because he did miss Inverclyde out in his comments earlier when he highlighted a few other areas. But certainly just on your point there, Mr Gray, regarding the existing estate and investment into that. But I know certainly I have engaged, I've spent a huge amount of time engaging with the NHS Greater Glasgow and Clyde, with regards to the Inverclyde Royal. And I know the condition of the IRH. Investment has went in, and it's been very much welcomed. And particularly, obviously, with the First Minister's comments on Monday with regards to additional treatments to take place there, that is very much welcomed within the community. But on the aspect of the fabric of the building, I cannot stress enough in terms of the two main challenges that the building has in terms of being wind and watertight, and we'll add on a third in terms of the heating system. So there are challenges there to extend the lifespan of that building. My preference would be to have a new build, but I know that's not going to happen tomorrow. But certainly extending the lifespan of the building and investment to go in. And I know the Health Board have been working on that particular project. They've been working on it for a few years, but clearly because of the capital situation, nothing could have progressed.
Yeah, and that's what we need to start to put our mind to, not just building new estate, but also look at how do we start to invest in that. There are some real practical challenges around how you actually do some of that backlog maintenance in a live site that's operating 24 hours a day, 7 days a week. So there are real challenges around actually practically, once you know what you need to maintain or to build up to heating, light, water, actually doing the building work is actually quite challenging when you're working in a live operational site. So I think we've got to work through how do we do it, as well as how do we find the funding. So we've got an ageing estate. 25% of the estate was built in earlier than the 1970s. So we've got an estate that's getting older every decade. And the amount of money we've got is not able to replace that at the rate we would like. So we do need to get into the backlog maintenance, but we can only extend the life so far. And also with existing infrastructure, we cannot always adapt to meet full clinical standards or technical standards. Just isn't physically possible within the existing estate. When it was built, it wasn't built for the types of technology you've got now, MRI scanners, so things like electrical supply. There are a range and raft of issues, but I'm hoping what the work we're doing now will start to highlight what we have to do and how we then approach that challenge, because I think it is a big challenge for us. Because good infrastructure is essential if we're going to deliver efficient, safe and effective care.
Well, I think certainly building the IRH on the top of a hill in one of the wettest parts of the country is certainly not the wisest decision of people of the past.
Yeah, land being available at the time was maybe the fact.
No, I know. No, I'm very much aware.
Yeah.
Just certainly to be parochial again for a moment, I know Port Glasgow Health Centre, a replacement of it, is a priority for the Health Board. So I don't know if that would come up in terms of the dialogue that they, or any report they'll bring forward to the government for future investment.
Yeah, we'll be looking at how we restart a primary care programme. We need to invest in something existing, to extend something existing infrastructure to deal with population. We've got populations with no infrastructure, and clearly we've got populations with an old building that's not fit for purpose. So we're looking, if you look at the Success of the Schools programme and what it did to communities, we're trying to see what can we learn from that around primary care. Because clearly they are more affordable. They're still expensive to build new, but they're more affordable than a new hospital. So as part of that reform work, I think it's what part can primary care play, and how do we invest in the right infrastructure to be able to then, so not just a replacement, what does Port Glasgow need, and how could that support some of the reform work. So I think that's a challenge, that's something we've got to work our way through, but I think coming up with a strategy around primary care, I think would represent a good value investment, I think, going forward, consistent reform and what we're trying to do. But it would be a different type of infrastructure from what we've currently got. So I'm keen that we don't just replace light for light, we look to see what could we do differently, what can we unlock in terms of that reform and change. So,
well, I think certainly the hub model with regards to the replacement in Greenock, so the Greenock Health Centre, and also the one over in Clydebank. I don't get many people contacting me complaining about the quality of care and the facilities at the new Greenock Health Centre. So I suggest that might be something to...
Yeah, but to open a hub in east side of Glasgow as well just now, and again that will show different ways of delivering a service to a community. Okay, thanks.
Certainly on the aspects of the consideration of obviously what we required and areas that are necessary, I would refer you to paragraph 100 in the report, and just it's the first sentence which I'll read out for the public record. So it was that the Chief Medical Officer's 23-24 annual report highlights the need to focus on a health and care system that focuses on equity, prevention and early intervention. When you consider the area that I represent, certainly obviously Greenock has got the worst SIMD data zone, and also it's sadly we've got about Inverclyde as a whole, when it comes to a range of negative health indicators, sadly Inverclyde is at the top. So on the aspect of equity, I would suggest that when it comes to any additional investment or any potential additional aspects of utilisation of the IRH, I would suggest that would actually help deal with the equity point, in contrast to centralising many services up to Paisley and also Glasgow.
Yeah, one of the factors we're looking at is what impact would that investment have in the community? What difference would it make? Because I think that's a key driver. If we're going to make an investment, what difference will that investment make to the population that's looking to serve? So I think we'd hope to see that. You'd see that featuring in terms of some of our investment decision going forward, that we're trying to build that in, not just look at actually a replacement doing the state's issues, but actually what difference would that make? What would that unlock? How could that bring together other resources to be able to address a variety of needs, not just health needs. And I think I used the East Glasgow Hub as a good example. That's more than just a health building, that's bringing a whole lot of services together that will support a population with similar attributes that I thought to Inverclyde. So yeah, I think your point's well made. I think that's, you'd hope to see it. We assure you that's what we're looking to reflect in terms of any investment decisions and choices. We've got examples in Fife where we're looking at similar populations where we could make a real difference with a relatively modest investment in some primary care or community care infrastructure.
Okay. So just on the report, on page 23, it's Exhibit 7, where it's the costs for the NHS with regards to the PFI contracts. And certainly over the page, at case study 1, there are 6 contracts that are due to expire in certainly the next few years, one of which is in my patch again at Larkfield in Greenock. And I'm old enough to remember how controversial it was to do the PFI contract for that. But so the auditor's report does indicate certainly some of the challenges for the earlier contracts when the contracts come to an end. Can you provide, I mean, you probably won't be able to kind of go into the details of each of these, five contracts that are there, but could you provide, sorry, 6 contracts, but could you provide a bit of information just regarding certainly some of the challenges that the NHS Scotland do face with regards to the end of these contracts, and what additional cost would there be for the contracts when they come to an end, and how easy would it then be to transfer them into, likes of the Larkfield one, into NHS Greater Glasgow and Clyde?
So maybe just to start off, and Alan might want to go some. I know Mr Simpson raised this with me last time I was at the committee, and we did send a letter with some detail around each of these contracts. I think we just need to be careful not to get too much into the individual costs, because clearly we're in a process of negotiation, and it would not be good to put that into the public domain. So we wouldn't want to do that. But I think in relation to the recommendations of Audit Scotland, particularly with some of these contracts now coming to the end of their terms, I think the recommendations are particularly around how we share the learning. And I think I'm reading that as it's not just within health, it's around the public sector, and that's why the engagement with the Scottish Futures Trust has been so important in that aspect. And also about how we provide certainty to boards and how we support them in their negotiations. And I don't know, Alan, you might want to say something about how your teams are working with those boards who are coming to the end of these contracts.
Yeah, so there's a couple of stages. First of all, there's a stage about, does the health service still required to use and access that infrastructure? If it does, then it's got to look at the provisions within the contract. Each contract is quite unique, so it's difficult to go into the individual. But each contract, I remember at the time I was involved in these PFI, they are quite unique, they are quite different. So there are provisions within the contract at the end of life, what happens, what the choices and options are for both parties. So that's what we've got a team of people, my own team, but also NHS Assure, Scottish Future Trust, providing support to the boards. In addition to that, to the legal advisors providing. So we're trying to learn and help boards through that. We've done a state of readiness assessment of them all. So we've given boards the kind of tools, if you like, to help them go into a negotiating position with, hopefully it's a strong negotiating position, able to work through what the best options are. There are costs, you're absolutely right, there are end of contract costs. 2 types of costs. There's one of making sure that the building we're getting handed over, if we indeed want it handed over, is the fit in state and has the maintenance obligations on the contract been fulfilled. So something about holding the contractor to account for delivery of the contractual arrangement. So that's part of the negotiation. And clearly then there's a commercial negotiation connected to the contract that has to be undertaken. And there's time periods through which you've got to do that. So it's not just waiting to the end. You've actually got to give advance notice depending on which option you wish to pursue. So there are some things that are critical in terms of the time path. There are some making sure the board has the right advice and support as it works its way through that, and also that shared learning, and also the bit of assessment. Does it actually need infrastructure? And if it does need it, how does it then look at the options available to continue to get access to it? 2 big ones in there, of course, are Wishaw and Royal Infirmary. They are pretty important here for those involved and know the geography of it. These are really important hospitals for which there's likely to be some kind of form of continuing need. So these are really important negotiations in terms of how we do it. The other ones are not less important, not going to throw them, they are important to the services that are provided there. So I think we're in quite a good shape in terms of being able to provide advice and support. Boards themselves have to take the legal advice, and it's up to them what decision they take. And clearly what we're doing is building that into the financial plan as and when we know the information. So we've done some estimates around, what the, from A, B and C's, what the options and what would they cost. But we won't know until the final negotiations are concluded. And that will be in advance of the final kind of end date or handover date, or whatever the next stage of that contract is.
Okay. Certainly, I'm sure that anyone who's watching this session, if they haven't looked at the report, I think the Exhibit 7, page 23, is quite startling, to say the least, in terms of the cost of PFI contracts. Between 98-99 to 23-24, 4.8 billion has been paid so far. And from 24-25 up to 45-46, a further 5.8 billion pounds has been paid out. That's a huge amount of money from the public purse going into, in the main, basic profits for companies.
Yeah. The only thing I would add is that the difference between the PFI and the non-profit distributing, there were different types of contracts The latter ones definitely was learning there from the PFI. Yeah. They are more favourable contracts. They're designed to still come with a cost, so I'm not going to dodge this around the cost, but they are different contracts with different measures and mechanisms to hold the contractors to account. So we've got a job to make sure we deliver on these. We hold the contractors to account for maximising the benefits of these new types of contracts, whilst also trying to get to the best deals we can in terms of the concluding PFI contracts. But yeah, there is a cost.
Yeah. Okay, no, thank you. Can I just move on to just another area? It's with regards to referring to case study 2 on page 29 of the report, and it's the CAPA model that's been highlighted. I find this actually quite interesting, to be fair, with regards to the NHS Forth Valley implementing the choice and partnership approach, CAPA, focusing on the service users. This is with regards to child and adolescent mental health services. With regards to this model, has that been considered to be rolled out to other health boards? Is that discussion, or those discussions taking place?
So the first thing I'd say is that it is it's encouraging that you've highlighted CAMHS, because that is an area where I think we've seen considerable progress, and that's very welcome. But yeah, in line with our overall approach, which is to absolutely look at what works, at what makes a difference, and then to seek to ensure that other boards are also looking at those approaches, then yes, we would absolutely expect other boards to be looking at this as well.
Just to say, Queen's Board and Grampian, we did implement it. It makes a difference. I can speak from first hand. This is an absolutely the right model to go. It makes a big difference in terms of engaging families and children in their care and getting them involved in the decisions about their care. That's really important, because if they're involved and they're part of these decisions, they'll engage and outcomes are better. So I think
also absolutely in line with realistic medicine.
It is. I think I've seen it first hand, and I can see the difference it makes. So I think thanks for highlighting. I think it's great. It's in the Audit Scotland report. It's again a good example. If we could roll this out, the difference it could make in terms of not just the access and the time to have access, but the quality of what we could offer and outcomes at the end of it, which are really important.
So I know there was a discussion earlier on and some questions regarding the activity and productivity within the NHS Scotland and various health boards. But the likes of the CAPA model, I mean, judging by some of your comments there, I mean, so that's one area where, if that were to be rolled out, that actually could have a hugely beneficial effect across the country.
Yeah. Example in the Grampian is what we did is we co-located with 4 services in 4 different locations, brought them into one building, repurposed the building, brought them into one building, and started all this model, and went from the worst performing board in CAMHS to one of the better boards almost within a small period of time. So it can work. So combination of using infrastructure, the right service model, this is a good example of how you can reform, and within a relatively modest resource base.
Okay.
And I think your general point that yes, there are opportunities for us to increase productivity, increase in efficiency, and all the work that we do and all the work that Centre for Sustainable Delivery support boards with is about making sure that we are getting the best performance that we can for the public purse.
Okay, no, thank you. And just one other aspect that's moving on from CAPA, just as with regards to the accident and emergency, the waiting times, obviously they do remain considerably below target, and it's a huge challenge. A few years ago, I did a 12-hour shift with the ambulance service. It was a Monday morning, and before I went, I generally didn't appreciate how busy the Monday would be, and the logjam that actually happened of the ambulances at the IRH, and obviously trying to take patients in. What I also didn't fully appreciate was I probably would have known somebody who had made a call and get picked up, and that proved to be the case. But just in terms of that, aspect, what additional work has been fully considered? I know that the First Minister spoke about this obviously on Monday, but I think that there is it's a real challenge in terms of improving that throughput, improving that the patient journey when they get to the A&E.
Yeah, and I'll ask John to come in on this one, but I think our focus is not just on once they get to A&E, but what happens before A&E and how, if at all possible, we can keep them out of A&E, and the ambulance service has been playing a huge role there as well. But John, do you want to talk about the work there?
Yes, thank you. And I think if I start with the redesign and changes we've made, and a number of factors are actually picked up in the audit report that reference and reflect some of this. But we've seen increasing the role with NHS 24 as an important first point of contact. The use of NHS Inform as a trusted source of information for people, and more people looking to use that. And then in terms of the Scottish Ambulance Service, redesign and change, so the Scottish Ambulance Service with an integrated clinical hub, being able to triage and assess people, paramedics arriving at incidents or responding, being able to use their skills and expertise, linking in with our flow navigation centres to consider whether a patient needs conveyed or can they be supported at home and their care provided there. And we've seen significant success through those initiatives that see a reduction in people being taken to hospital. And that's important because that's right care in the right place. Alongside that, I've referenced flow navigation and the ability to direct people to the right resource, which isn't always our hospitals or our A&E departments. But when we get to then into people needing to attend accident and emergency, then we have different flows at that point. We have people that go through minor injury, minor illness pathways, can be directed into a same-day emergency care pathway, but also then a strong commitment within our A&E departments to only admit people if they need to. So from an A&E perspective, we'll admit about 26% of people that actually attend. So tremendous efforts in our clinical teams to support and manage care, assess people, and if they don't need admitted, support them either back out in the community or discharge them if they no longer need care. The challenge you describe around A&E, of course, is we tend to focus on A&E because but that 4-hour measure is really a whole system measure. It's a sense of how the system's performing. And so the area we've been focusing in on, whilst recognising we need to continue to support our A&E teams across the country, is on how do we manage the admitted pathway. So when a patient does need admitted, how do we deal with what is currently where we see the delays? And so we've been working, we've referenced many times the Centre for Sustainable Delivery, which is a national resource, national improvement resource for us, working with boards. And again, in the audit report, there is reference to the work that CFSD have carried out, analysing data, working closely with boards, focusing on areas of improvement that each board and each site can consider. And what came out of that was looking to lessons from some boards where we've seen the benefit of short stay assessment episodes, but also looking to see how we can address some of the longer stays in hospital. So creating that capacity in the inpatient space to ensure that flow from the A&E department is a particular focus for us. And of course that links to the work that we've referenced earlier on delayed discharges. So there's a considerable activity here. We have clinical teams, clinical leaders in the Centre for Sustainable Delivery that go out and engage with clinical colleagues across the country to share learning and to help challenge and support change in our sites.
So there's reference earlier on regarding the national conversation and the discussions that take place with the different specialisms. I would assume that they have input into this centre and the folk who are actually on the ground who are attempting to deliver this, their concerns and issues and suggestions are actually being listened to.
Very much so. It's our clinical teams on the ground that we they know what changes, what could be done. They know where the challenges are. So absolutely empowering those teams, working with them, and not everything works, but I think through through a programme of taking an improvement focus to drive improved performance, then it's allowing teams to try things that might not work, but to learn and try other things. So that's very much our Centre for Sustainable Delivery approach, is to support improvement and to listen and to engage. We're very much about what are the local teams and what can local teams do. They're the ones that can own the solutions if they're empowered to deliver the changes they think can work.
So the next time I talk to healthcare professionals based at the IRH, and I make them aware of this this contribution, then I can be assured that they will indicate that they are being listened to, they feel as if they've been listened to, and considerations with what they're putting forward have been taken forward.
And that's certainly, well, I can't speak for that specific, but that's certainly the approach, and what we expect the position to be is that engaged clinical teams. And I accept it doesn't always work every time, but that's certainly the way in which we'll take change forward.
Okay, well, thank you. Thank you, Convener.
Thank you very much. And waiting like a coiled spring is the very patient Deputy Convener, Jamie Green, who's got some final questions to put to you. So thanks for your forbearance, and I'll pass over to Jamie.
Thank you, Convener, and thank you. Good morning. Ms Lamb, on Monday, the First Minister made a speech on the state of the NHS in Scotland, and he quoted the NHS as being fundamentally resilient, fundamentally robust. No sooner had he stood off the lectern, the Royal College of Nursing in Scotland responded as follows, and I quote from their director: "Many nursing staff will simply not recognise the First Minister's description of resilient and robust NHS in Scotland. Their experience is a service struggling to meet the needs of patients, leaving them to carry the burden of being unable to deliver the care and treatment required." So which one is correct, the First Minister or the Royal College of Nursing?
You might expect me to say this, but I think that they're both fundamentally correct. I think that the NHS is actually resilient and robust, and I think that when we look across the country, and as the Auditor General has recognised, and as you yourselves have recognised in some of your questioning, we see areas of really good performance, and we see areas that are finding it much more challenging. And that is reflected in the experience of staff as well. That some staff, there is absolutely no doubt that there are some services and some areas that are under extreme pressure, and where staff are absolutely feeling the impact of that. But that is not absolutely universal across every service. And I think it's really important that we recognise that, and that we're not sort of talking down services and the work that people are doing.
So I'm not talking down nurses,
No,
and I really need to be clear about that, because I hear it far too often in the chamber. I wouldn't expect it in committee. No one's talking nurses down. I'm quoting nurses. I'm quoting the body that represents nurses. That's their feeling. That's their strength of feeling, not mine.
And I absolutely accept that. I think what I'm saying is that we recognise that there are areas of our services, particularly around the front door, particularly around areas of our hospitals that have got far higher occupancies that we would wish, where absolutely people are feeling those pressures and living and holding those pressures and that risk. And that is why we are so focused on, and all the activity that John has described to you around trying to ensure that we don't admit people into hospital unless we absolutely have to, and all the work that we're doing with colleagues across local government and our IJBs to try to ensure that people are able to get out of hospital as soon as they are ready to be discharged, because actually that getting that flow through the hospital system is what will make a difference, and where people will start to see that actually that intense pressure that we see in some areas reduces. So that is absolutely what we're focused on.
I mean, let's do a bit of a reality check here. You agree with the First Minister that the NHS is resilient and robust, but not a single NHS board in Scotland is meeting their 12-week outpatient or inpatient targets. Not a single NHS board in Scotland is meeting its 18-week planned care targets. 1 in 6 Scots are sitting on an NHS waiting list. That's nearly 900,000 people, of which nearly 10,000 have been waiting over 2 years on a waiting list. And to top it all off, Scotland has one of the lowest life expectancies in Western Europe. Does that sound to me like a resilient and robust health service that is fit for purpose, that is delivering for the public?
So I would absolutely accept that performance is not where we want it to be, and that.
But you said that last year and the year before and the year before. This is an ongoing theme, as the Auditor General reports.
Yeah, so I would accept that performance is not where we would want it to be. I think the Auditor General does reflect in his report the amount of work that is going on to support services in the light of, significant inflationary pressures and continuing backlog from COVID and continuing pressures still coming through the system resulting from COVID. So it is taking the system longer to recover than we would have wished. I think we are starting to see, so the Auditor General recognised in his report that we're starting to see some improvements. And certainly when we look at the management information, the published information up to the last published quarter, which was September, I think we have seen increases in activity and a reduction, I think 11,000 reduction in the waiting list for diagnostics. So, and that is a reflection of the 30 million that we were able to invest in 24-25. So what's going to be different? What's going to be different going forward is that we have secured that 200 million investment in the budget to absolutely focus on bringing down waiting times and improving the capacity across our system, including in primary care.
What are you going to spend the 200 million on? Because it's a big number and it's welcome. But I don't quite understand how that translates into getting waiting times down. So, well,
I'll hand to John in a second, because we've got 100 million of that earmarked to devote on waiting times. I think he's already described some of the work, but I will just hand back to John and let's just go through where we are. We're still in that detailed planning phase at the moment, but I think John can give you enough of the headlines around how that money is going to be deployed.
Thanks.
Yeah, thank you. So I think the first point I would make is that we are doing a number of things to address the need to reduce long waits and improve access for patients. First is not just to focus on the 100 million, but to also focus on optimising the core planned care activity that we have across Scotland. And as Caroline has referenced, we have seen, looking at the last September published data, we have seen increases, welcome increases in the number of inpatients and day cases that are being treated in Scotland. But we need to go further, hence the investment. So we'll look to optimise that core. That's the first thing we'll do. And we'll work closely with our boards on that. In terms of delivering that and bringing that plan and detail forward. Secondly, on the 100 million that is being available, as I've referenced earlier, this won't be a spread across Scotland, so it won't be an allocation to boards, and I've made that very clear to my Chief Executive colleagues. Mm-hmm. But we are working with our Chief Exec and board colleagues to look and ensure that we bring forward a plan that, as I said earlier, optimises our NTCs, particularly for orthopaedics and ophthalmology, which is their principal focus in many, but also recognising that we have got, that boards have said to us, we have other capacity that we can bring on if we can secure the funding for that. So again, this isn't just giving money, it's about being clear what that will deliver. And then we are coming in behind that. So I referenced earlier, Gartnavel, Inverclyde Royal was in that in terms of orthopaedics. So we're looking to support our colleagues in Greater Glasgow and Clyde to deliver additionality. And that's their plan that they've brought to us that we are supporting. We also have invested recurringly in Stracathro Hospital in the last couple of years to maximise and optimise that facility for the north of Scotland and on the same principles as a national treatment centre. And then in addition to that, we have been able to identify other capacity for ophthalmology, for example, in the Queen Margaret, and then, of course, the Golden Jubilee. So our approach is local, where we can deliver locally and where we can be committed on the delivery, a regional or collaborative approach through our NTCs, and then a national approach where we think that we need to support boards to get patients treated, and where can we deliver that. So a very different approach to our plan, but a very focused one.
Okay, and so let's look at some of the detail on this. On orthopaedics particularly, there are huge amounts of people waiting, many over 18 months for treatment. Now, these people are in pain. You know, let's cut to the chase here. You'll obviously be aware that there are various models of treating people. In England, there's a more flexible approach, for example, which does include the use of private care, which is funded through the NHS. But, you know, if you're a patient, you're waiting on a new hip or knee, do you really care where you're going to get it, as long as you get it sooner? If you have the choice of getting it in 3 months or getting it in 3 years, what would you choose? So how open are you to new ways of delivering service more quickly to people?
So I think start off by saying that, yeah, we recognise that orthopaedics is one of our biggest challenge, and clearly we want to shift that position and ensure that people are being seen quickly. So we are really open to doing whatever is necessary to bring down those lists, so long as we can be assured of the cost effectiveness of that approach. And so we are currently focused on looking at what we can do, as John's described, using NHS capacity. But we have also used, currently we have mobile units provided by independent providers that are part of the solution that's helping us to bring down some of our diagnostic weights. John, do you want to?
Yes, and this is something that we have done periodically, is that we do utilise independent provision. We've done that, as Caroline has said, for CT and MRI. So I think at the moment we've put, I think, in the region of 10 mobile units across Scotland. And that's been enormously helpful in supporting access. But at the same time as doing that, we're also looking at how we build sustainability into the NHS, because we cannot rely on that as a long-term model, and so as part of our diagnostic plan, and we've referenced inpatients and in the main, but we also need to be mindful of our new outpatients and our diagnostic radiology and endoscopy weights, and we're very much looking at focusing not just how do we bring the backlog down, because that's important, but how do we look at sustainability going forward. So we're taking I guess, parallel approach here to ensure we're also looking at sustainability.
I mean, the figures are atrocious. Can I point your direction to page 48 of the Audit Scotland report, which is one that I flagged in a previous session of Public Audit Committee. What you would normally expect to see on this page, as I'm pleased to see in other tables, is little green ticks where the target's been met. On page 48, there's not a single tick on this page, not a single green tick anywhere on this page. And the numbers speak for themselves. The targets are 95%, 100% and 90% treatment. Now, they're ambitious, I get that, and I know health services is very challenging right across the UK. But look at the performance measures here. Look at the inpatient treatment within 12 weeks of a decision to treat. The poor people in Grampian are sitting at 46% of 100% target. Fife and Forth Valley, 47%. Lanarkshire, I mean, poor Lanarkshire, it's 61%, 46% and 60%. Nowhere near the target. There are huge amounts of people waiting for far longer than they should be. £100 million isn't going to scratch the surface looking at these numbers, is it?
So we absolutely accept that these figures are not where we would want them to be, and the reason.
Oh, I know you keep saying that, but how are we going to fix it, though?
The reason why planned care, I think, is particularly challenged is because that's the area that was particularly hit during the pandemic, and we have still not been able to recover from that backlog. As John's described, the approach that we're taking is around maximising out our core capacity, and that includes innovations such as theatre scheduling, which helps us to improve the productivity of our theatres. So all of this is about, as John described, developing that more sustainable approach, and at the same time having secured some investment that will make a difference and will start to bring those lists down and will tackle those people who have been waiting the longest. So we need to keep going with this, and as John says, we need to keep the same that parallel track approach, which is about tackling the backlog, but doing that as far as we can in a way that absolutely helps to increase the capacity and the resilience of the service.
Well, I think for the sake of all our constituents, I hope we don't have to have this conversation in 12 months' time at the next report. Let's look at two metrics. Ambulance waiting times. Last week, 5 health boards, across 5 health boards, including 2 in my region, Ayrshire and Arran and Greater Glasgow and Clyde, the waiting time for yellow calls exceeded 3 hours. 3 hours for an ambulance. We've heard of horrific anecdotal stories of people waiting far longer, but clearly people who phone an ambulance do so as a matter of last resort, having exhausted other avenues and perhaps given up on NHS 24, of which over 100,000 people hung up on last year, waiting to be answered. So when you call 999 and ask for an ambulance, presumably it's quite serious. Why are people waiting 3 hours for an ambulance to turn up? What is going wrong in the ambulance service?
So I'll come to John on this one as well, but I think that first of all, and for the purposes of the record, we need to be really clear about the triage process at the ambulance service. And I don't have the performance metrics in front of me. We can provide those to the committee, because I think it's really important that we focus on those people who are most acutely ill and making sure that they get an ambulance in the shortest possible time. That may mean that people who aren't as unwell need to wait a bit longer, particularly when services are particularly busy. But that is accompanied by the ambulance service having done that, been through that triage process. John, is there anything you want to add to that?
So I was actually meeting with the Scottish Ambulance Service senior team yesterday, and we were looking at their overall performance and position and the changes they were taking through. So I think, as Caroline says, firstly, it's important to recognise that for those immediate life-threatening calls, then they are responding quickly to those calls. And I think that's important that's said. I made reference earlier to the triage model that they have, their integrated clinical hub. So they're engaging with patients who are calling in. They are trying to ensure the right response for those patients. Now, I agree there are still patients you've quoted who are waiting too long. But the ambulance service are doing everything they can to respond to those asks. And when they can't do it as quickly as they would want to, they are staying in close contact with those patients.
Mr Burns, why would they not be able to respond more quickly? Is it that they don't have enough ambulances, or they don't have enough staff, or that demand has increased exponentially, or is it all of the above?
So I think one of the things that is very specific to this is the hospital turnaround time. So we know that there are some, and you've quoted some sites, but in certain parts of Scotland, we have some very significant challenges in terms of ambulance turnaround time that exceed the standard that we have set. And that impacts then on the ambulance services response, and they're having to manage the consequence of that.
Is that because people are A&E's chock-a-block? Ambulances are sitting outside queuing with people in the back of them. Yes. What sort of experience is that? I mean, if you're sitting in the back of an ambulance for hours, or even being treated in an ambulance because there's no place, that ambulance can't be freed up to go out and treat somebody else, and it's not a good experience for the patient. It's a lose-lose scenario. So what are you doing at the other end to unblock that?
So that's the work I described earlier in terms of looking at the admitted pathway from A&E into an appropriate specialty bed, and and that's the work the Centre for Sustainable Delivery have been engaged in with boards across Scotland, and where there are particular challenges in sites, again referenced earlier, our clinical leadership that we have in the Centre for Sustainable Delivery, going and meeting and talking to local teams to see how they can support improvement that helps that ambulance situation at the front door. I agree with you, it is not the experience we would want for anyone, and we are absolutely committed to do all we can to improve that.
Now, the target for A&E treatment is 95%. Now, that can be someone who's admitted to hospital, if that's considered necessary, discharged, or treated and then discharged. The current average performance is 69%, so that exactly marries up with what you've just said. There are far too many people in A&E who have not been treated or moved on or moved out of that environment, which then has a knock-on effect on ambulances. What is the issue at A&E specifically? Is it people are turning up when they shouldn't? Is it that it's understaffed? What's the problem? What's causing?
So I think the first thing I would say is I've referenced redesign of urgent care, which came in 2019, and there's elements of that referenced in the audit report. That has seen, I would want to just acknowledge the way in which our communities have responded to our right care, right place, right time message, and how they then access, whether it's NHS 24 or community pharmacy or their GP or out of hours, a range of services, and our communities across the country have responded positive to that. And again, it's referenced in the report, but we have seen a reduction in the number of people presenting at A&E. We recognise some are coming as planned, and we've referenced it. I think it's from the 4th of February. Those attendances quite small just now, but they'll be built into the numbers. So scheduled attendance, usually for a minor illness or a minor injury. But again, I would pay tribute to our teams in A&E because they're managing different flows, and because of the challenge in the admitted pathway, they are having to provide care for people that would normally be admitted into a specialty bed. And that is the issue. And that's the issue we are focused on trying to address, is the admitted pathway. I think if from our data, if we can address the admitted pathway, then that will improve the position in our A&E departments. They are dealing with the consequences of that challenge in the admitted pathway.
Of course, it's already been mentioned that one of the issues at the other end of that is delayed discharge. So we've talked a lot about the flow of people going into hospital, but getting them out surely is key. Now, the statistics on that are equally atrocious, I'm afraid to say. In 2023, there were 658,000 days, bed days, taken up in delayed discharge. So those are days that could have been occupied by all those people sitting in A&E waiting to be admitted. We don't have the full statistics yet for 2024, but doing a year-on-year analysis from November to November, there was a 7% increase in delayed discharge days. So that, my fear is that number is not going to be great for 2024 either. Now, of course, the government promised to eliminate this completely. I don't know how on earth they thought they were going to do that, and it was an admirable ambition, but it's clearly not happening. Now, we had a conversation earlier where you said you admitted as being the accountable officer for NHS health and social care, but of course many of the levers required to deal with delayed discharge are entirely outside of your control. That must come as a huge source of frustration too. You can't really fix this problem, can you?
So I think it's a challenging problem to fix, and it can only be improved. The position can only be improved by working across systems. So as I've referenced a number of times, getting the flow through hospital, getting people out of hospital when they no longer need to be there is critical for improved performance and indeed for the people who are in hospital. And there are ways in which, for people who aren't dependent on social care packages to get out of hospital, we need to improve the rates of discharge for them. But fundamentally, and remembering that 97 people are discharged without delay from hospital because they don't need any further support. However, for people who do need further support, we need to work with our local authorities and through integrated joint boards to improve that. And we have taken exactly the same approach. We don't have the same levers, but we've taken exactly the same approach as we've taken to improvement in other areas, which is around getting the data. That in itself has been a challenge, and I would want to recognise that we have made significant progress in terms of that access to sharing of social care data not just in government, but with every bit of the system. So making sure that each element in the system has access to that data, so that we're able to understand the variance across the country. Because again, this is back to, we know there are some areas where, I think Renfrewshire, where it's 13 people per 1,000 population are delayed, and areas such as Highland where the figures are much, much higher than that. So we need to get underneath that, and there is further work to be done to understand what are the things that are driving that. So what are the things that good systems do really well? But also, I think, questions to be asked about the level of investment, whether that matches the demographics, and really unpicking all of that. So you're right, the levers are different, but at the end of the day, this is all about people working together, because this is an end-to-end system through primary care, community care, acute care, social care. All the partners engaged in that need to work together to make it work effectively. And we all need to learn from the areas that are doing it really well. As John said, we try things sometimes and they don't work, but when we try things and they do work, we absolutely need to spread and scale them.
I'm all for people working together and agencies working collaboratively. We hear a lot about it. It's civil service lingo, but the reality is the numbers speak for themselves. Something's not working here, and clearly the government is failing to meet its objective in delayed discharge, and it's causing huge amounts of issues. Have you had any feedback at all? I mean, let me ask a more fundamental question. Do you think the IJB model is broken? Because it doesn't seem to be delivering for folk.
So I think that the principles behind the IJB model are, absolutely valid in terms of providing that interface around health and social care and integrating the system. I don't think that you would talk to anybody in the system today who doesn't understand the absolute importance of integration and of making sure that everybody understands their responsibilities in the system. I think the challenge have been around capacity in social care, and there are, as have been rehearsed elsewhere, there are issues around workforce capacity. I think there's also issues around the financial sustainability in social care as well that will impact on the smooth operating of the whole system.
That's a whole other committee
session.
It is indeed.
Isn't it? It is indeed.
Just my final question is something slightly off-centre, but can you explain to me what has been done to improve the issue of whistleblowing in the NHS? Many MSPs will be contacted by constituents, particularly those who do or did work in the NHS, with a number of complaints or anecdotal evidence of malpractice, which has led to patient safety being put at risk. What has been done to improve those processes? Because I've certainly dealt with a number of cases where NHS practitioners feel that the current processes are simply not working, and the levels of frustration as they go through us and then to ministers, the responses that they get are extremely poor in terms of dealing with those complaints or those allegations. Do you think the situation is better than it was?
We have certainly, so there's been a lot of work done to try and ensure that people are confident in raising concerns, and to ensure that they're also confident that if they raise concerns, those concerns will be acted on. So in terms of the range of measures that we've got in place, we have independent whistleblowing champions appointed on every NHS board. So at the level of the top layer of governance in NHS boards, we have board members whose responsibility it is to be the champion in relation to that culture of openness, transparency, ensuring that people feel able to raise concerns. We also have confidential contacts in every NHS board, so there will be somebody who, staff members, if they have a concern and can understand why they would feel anxious about raising that they can go and talk to. And we also established the Independent National Whistleblowers Office. So that is, again, an independent organisation who, if people feel that they're not getting the responses that they feel they should, or if there are matters that they feel they can't raise, there's also then an additional layer of where they can approach. In terms of how we monitor that, so So I referenced the iMatter survey earlier, and since we established those processes, we've added a couple of additional questions into that survey to monitor exactly that. So do people feel confident in raising complaints or concerns, and do they feel confident that those will be acted on? And I think we're running at, this is, I think it's in the 60s, 66%. It's a figure that sticks in my head around how people feel around that. And clearly we will need to monitor those trends, because that's the relatively newly introduced question. So I think we are working very hard. I would also add that culture in organisations is one of the things that we discuss with boards, with chairs, with chief executives, with the leadership, because that's so important when it comes to people feeling that this is an organisation where you can raise concerns.
Thank you very much for that. Thank you, Convener.
OK, well, thank you very much. We've covered an awful lot of ground this morning, and I suppose if the budget is passed in a few weeks' time, it will rise to £21 billion that you will be the accountable officer for, Caroline Lamb. So it's important to us as the Public Audit Committee, because that does constitute 40% of the entire Scottish budget. It's important for us to scrutinise what you're doing and examine areas where things aren't going quite as well as we would like. And I think there is a great deal of public interest in health and social care, and I think the National Health Service remains probably the best loved public institution that we've got. So can I thank you very much for your time, your cooperation this morning in answering the questions that we've got, that we've had, and Caroline Lamb, Alan Gray, John Burns, thank you very much once again, and I'm now going to move the committee into private session. Thank you.